Dr. Boersma, I would like to challenge you on the high risk of bleeding in patients on warfarin. There was a recent paper in Circulation that showed that almost irrespective of the risk for bleeding, the advantage of providing oral anticoagulation was always superior. And the largest risk for bleeding were patients who were overtreated with warfarin, those with a very low CHADSVASC score. And I would like you to comment on that, please.
I did not completely understand the nature of the question, actually.
What I think is that there is an exaggeration that the risk for bleeding is higher than the benefit of anticoagulation treatment. The net benefit of warfarin or other anticoagulations is still better than the risk for bleeding.
Okay, I understand your point. No, I think you're right. I think that in all patients, and we know that from a lot of trials, that even though you have bleeding, that this still is better than, the net benefit is still larger than giving aspirin or other stuff. But if you can achieve, let's say, left atrial appendage occlusion, then you still have the same benefit, but you do not have the bleeding risk. And that obviously, I think, is the advantage. I don't know if that answers your question. You have the advantage, but not the disadvantage of keep on using oral anticoagulation.
I'd just like the panel's opinion. If you have a patient who has significant spontaneous echo contrast, he's had, throughout the left atrium, he's had stroke on warfarin with adequate INR. Now, if we occlude this left atrial appendage with a plug, would you all be happy just to leave him on, the aspirin and Plavix, say, for 6 months and aspirin alone, or should he have a plug and warfarin, assuming he can take warfarin? But he has a stroke with adequate INR, can take warfarin. How would you handle these cases?
I think it's a very good comment, because this is obviously a question that has been raised, at least to me, but Professor Camm may also comment on that. In referring cardiologists who perform a TEE in their patients to look at that, they say, well, it looks nice and all, the left atrial appendage occlusion, but if we see spontaneous contrast, is it safe to stop oral anticoagulation now? And I don't know whether there are any data to support that it's safe or not.
I don't think that there are data. Obviously, medical approaches to this could include swapping to one of the novel oral anticoagulants rather than moving on to a left atrial appendage occluder. It could include adding antiplatelet therapy to anticoagulation. There are no data, I think, specifically with regard to a high density of smoke in the atrium with regard to any of these solutions. But prior to the plug, certainly, and prior to the novel oral anticoagulants, the standard move was to either choose a slightly higher INR range or to add antiplatelet therapy. Those are still possibilities, but I think it's better to move to the plug. And then the issue of whether you maintain an anticoagulant or not is an open question, and there are no data to support one way or the other at the present time.
Excuse me. Is there any scientific basis to use aspirin and clopidogrel after the implantation in patients who have has-bled 3? Because it's not compatible with the guidelines if you're using aspirin and clopidogrel and you have has-bled 3. Of course, 6 months, but what's the basis of this?
Well, as far as I know, there are also not many data on that, because obviously there are not a lot of data on the Watchman. What we only know is that after Watchman occlusion, and probably also after the Amplatzer, people use antiplatelet therapy, aspirin and clopidogrel for a limited amount of time. But I don't think there are subgroups where we use it in low or high has-bled scores, or subgroups where you have high or low CHAD scores. I don't think that that small detail is actually available.
We will have a presentation specific to that topic. Maybe we keep that question. Dr. Kanagaratnam will talk about this, pills after the implantation. I think he has prepared the data for that. Dr. Hattada.
My question relates to the combined procedure of occlusion and pulmonary vein isolation. So maybe it's addressed to two electrophysiologists in the panel, interventional electrophysiologists. My concern is that when you once do the pulmonary vein isolation, basically we have a 50% chance that the patient will need a second procedure. Do you see any possible interference of the occlusion device with the second procedure? And maybe if there are some differences between Watchman and Amplatzer devices in potential interference.
Well, I think that there's also going to be a presentation which probably discusses more about that. What I know from our database, we use the Watchman at this stage, and we have performed redo procedures in patients where we had no problem at all, because the Watchman is obviously more inside the appendage, and only rarely do we need to attack the appendage as such. So for the Watchman, we have not had any problems in performing a redo case in the patient with a Watchman. And in case you do, that would not be possible, we still have, in that case, we still have minimal invasive surgery, which is an alternative to an endovascular approach. And actually in our patient population, 2 patients had a minimal invasive surgical procedure where obviously the appendage was actually removed with the Watchman inside, which actually shows very nice re-endothelialization of the device. So in our situation, it has not been a problem, but with the Amplatzer, I do not know.
We performed 2 redos in an Amplatzer patient, and we had no issues, but we were very careful at the ridge, at the left atrial, at the ridge between the left superior and the left atrial appendage. That is clear. I think we went slightly into the vein at the ridge area, and it went fine. We had no issues in the redos.
Hi, I have a question about the intraprocedural heparinization when you do a combined procedure, particularly in patients who cannot take warfarin, so you know they're not going to be on warfarin afterwards. How would you handle the anticoagulation in and around the time of the procedure, but perhaps more importantly, in the 1 or 2 days after, where we know after an ablation procedure there's a high risk of stroke?
Well, I know from a colleague or several colleagues that some EPs perform aspirin Plavix instead of warfarin after ablation in paroxysmal AF, and that's what I also do in those who have some bleeding issues. That's not guideline. No. That's not what the guidelines recommend. So there are a few hundred patients followed after aspirin clopidogrel on a single center basis outside, and they have very good results. Selected patients for this approach. So I have no personal issue when we do combined procedures to put them on aspirin clopidogrel. Those with extensive lesions outside the pulmonary veins, I would go for oral anticoagulation. But for a purely PV disconnection, Dr. Tondo will talk about this issue in more detail, but for purely disconnection and not hugely dilated left atrium, we try to go with the aspirin clopidogrel approach.
Yeah, also in our experience, we have used aspirin and clopidogrel only in these patients, obviously at a slightly higher risk for post-ablation stroke, which is usually so in the first week or something. But there are indeed some patients. We had a couple of patients that were referred to us with a subarachnoid hemorrhage that were actually had a very big contraindication to have oral anticoagulation or more than aspirin. And in those patients, we send them to the surgeon for minimal invasive surgery instead of going for a ablation plus occlusion procedure.
I would like to Dr. Camm regarding the aspirin therapy alone for young patient with CHADSVASC score 0 or 1. Do you really consider that aspirin therapy is a very effective treatment for protecting against stroke, even in young patients with paroxysmal atrial fibrillation. Because in my mind, I consider that in 2012, there is no alternative for protective patient against stroke. That is no treatment or anticoagulant therapy. Do you really think that aspirin therapy alone is, we have enough evidence that it is better than placebo in this patient?
No, we don't have enough evidence that it's better than placebo. The evidence that we have, according to the heart meta-analysis, is a 19% insignificant, non-significant reduction associated with aspirin. If you add to the aspirin trials some other antiplatelet trials, you get a 22% reduction in stroke, which is just statistically significant. So that for aspirin alone, there isn't any significant data, even in the largest of the meta-analyses. And it's all driven by a single trial, which was internally highly inconsistent. And most people believe the aspirin data to be very insecure. What we do know about aspirin is that it is associated with an increased bleeding risk. And in the absence of any data to demonstrate a reduction in stroke, it doesn't seem appropriate to use it. And therefore, most guideline committees are trying to remove aspirin from the guideline. Most have been persuaded to leave it there as an option. But as you saw with the ACCP, they very specifically said it was if the patient wanted to take the aspirin, but they encouraged doctors not to prescribe the aspirin of their own volition.
I have a question about I may have misunderstood, but as I understand right, that all studies on this subject has been that you have followed in the study a lot of patients who have got the LAA closure and compared to the general population, you could say, what should we expect? Have there been any study where patients have been randomized to patients who are eligible for this device closure, who has been randomized for getting the closure and not getting the closure, followed up with and follow up afterwards? Or do you know if there's any such study on the way? But that could be interesting.
I mean, we have randomized trial like Dr. Meerkin presented, the PROTECT AF against Coumadin, but we have no study at this point where a patient, potentially eligible patient for this procedure, are compared with standard medical therapy. But this is something that we potentially need, as you mentioned. I think it's a good point. They did that for aortic valve implantation, for example, the PARTNER trial. They randomized patients that they were not eligible for surgery between valve and medical conservative therapy. This is certainly something that we can imagine in that population of patients. So you can take a group of patients that they are potentially eligible for that procedure, not eligible for anticoagulation, for example, and that you compare with standard therapy. I think it should be done, I think, at some point.
And I think in addition, we need data against the new drugs also, I think, to be fair enough, because this is the future, and we have to compare against the best available treatment. So this is a challenge for the occlusion device also.
What would be interesting actually is if we reanalyze the PROTECT AF data with the CHADSVASC score. And I don't know whether that sub-analysis or let's say read is underway, because that is obviously for the European situation would be very helpful.
Do we have more data? More questions, please?
So I have a question for Dr. Cook. If you go through all your specimens and you look at the appendage, we've had some experience in implanting the devices in appendages which look anatomically suitable, albeit a bit small. But if the compliance of the appendage is, if you like, high enough, i.e. it can accept and stretch, then the device should fit. And the question is, in your experience, is there much difference in compliance in the appendage? And if there is, are there any markers of compliance that you could think of, we could look for, particularly on TOE, to try and predict which of these appendages will stretch to allow the device to be implanted?
Yeah, it's a very interesting point. I mean, I think certainly there are changes in compliance or changes in structure that you can see in patients with that have had AF, and also you know, with other sort of left ventricular problems. So certainly there's changes you can see in the atrial appendage. I mean, they're not all as thin-walled as I've shown you, and I showed you a couple of examples where there was sort of fibrosis. That's the initial reaction. I mean, how you actually measure that, I don't, is a tricky one. I mean, you can certainly see. I mean, when you see the echo pictures, you can see that some appendages are certainly less compliant. It's normally a very mobile structure, and you certainly see those changes. You see it becoming less mobile, less able to stretch on with AF and changes. So I mean, I think it's an important factor. I don't know whether you could correlate it exactly with, you know, histologic appearances, the changes, but I guess 3D echo, and I mean, for me, three-dimensional analysis of these appendages is the key.
And can I extend that question to the implanters? Are there any features of echo or the angiogram that when you look at, you think, you know, prior to getting there on the pre-assessment TOE, you think that there could be a problem here, and these are the kind of patient that I would envisage kind of a 25% failure rate, let's say.
I think in general you're right that there obviously are challenging anatomies. In my experience is mostly with Watchman, but I think that we will have more speakers today talking about that. But what you have, when you have a very strong curve in the left atrial appendage, the tendency for the device is to tilt a little bit, and you have a piece of pie which is always left at the beginning of the left atrial appendage. And obviously sometimes if the appendage is not deep enough, you have some problems in landing the device. So there certainly are markers that tell you that you're in for a very difficult procedure, but that varies between the different devices, so it's hard to give a general comment on that, as was mentioned by Dr. Cook.
I think what we can say so far, with all the registry that we have, the success rate of closure is very high, even if you are using only one device. So I will certainly suggest that you should be able to use more than one device if you are working in that field. But even with one device, the success rate is, given the amount of variation between the individual, between the patient, it's very high. So I think most of the time you're able to close that structure despite the variation between the patients.
But I would argue though that we are able to close it, but the definition of closure and let's say the follow-up of what does that mean? For instance, there are some data now showing that if there are gaps, that there are some gaps left depending on the type of device. But we don't actually know for long term what that means for the stroke risk, which is the most important part.
And the interesting point concerning this, the definition of closure is probably not the same if you're using one device and the other one. And so what is the closure? Is it a complete exclusion of the appendage? Is it a closure, an exclusion of the pectinetic muscle? We don't know what is a closure. But at least closure, it's probably the ability to put a device in the appendage. Some form of closure.
May I have a question for Dr. Cook? Because that pouch that you have, which in addition to the left atrial appendage is obviously a bummer, because you don't want that. You want to occlude the appendage. So do you think that, for instance, with the Amplatzer, you're able to go in front of that pouch to close that also? Or in how many cases do you see that pouch? And is there any relationship of stroke to that pouch? Is there any data on that?
I'm not sure there's any data on relationship to stroke to the pouch, but I mean, it makes sense that you would need to close any significant, pouch or diverticulum, if you want to call it, in addition to the os. I mean, so I suppose devices with a disc could potentially cover that structure. They tend to be, as I say, in the sort of inferior aspect of the os more commonly. Quite often you see pectinate muscles spilling over the os in that region. And I don't think they're necessarily significant. If there's a few muscle bundles, you're going to have a little gap maybe. But But if it develops into more of a lobe or a distinct pouch, then I think that is a potential problem. You're very unlikely to cover that completely with a kind of circular device.
Can I ask, Andrew, is there any particular morphology of the appendage which is more likely to harbour thrombi or to be associated with stroke?
That's a very difficult one, isn't it? I mean, I don't know. I don't know the answer to that, but I would say, ones with very prominent, divisions or pectinate muscles that are going to change the flow and create perhaps more stasis within the lobes. So ones with kind of large dilated lobes, but with prominent divisions between them, that's the most likely. I think the thrombus anchors in the pectinate muscles. So yeah, they would be one. I think it's fair to say, though, I mean, I've shown you some sort of frightening anatomies that probably 80%, I think, are probably, amenable to closure. But it is the sort of smaller group that's important to know about, and just to try and
I wondered if
know whether you should close or not.
I wondered if anybody had done, say, tissue factor staining in different types of appendages to see whether or not there were inflammatory bases for clot formation in different types of appendage.
No, I don't. I'm not aware of any studies. I mean, that's an interesting topic.
So I guess at this point it's the time to. Do we have
one question?
Okay, one last question maybe.
I have the feeling you have just answered my question before, because I wanted to ask about how comfortable you feel with the residual leaks during the procedure. I consider it quite a challenge to define 3 millimeters versus 5 millimeters residual leak at the moment of implantation. We experience some leak through the device. It's difficult to say how is it going to be in 3 months. Maybe it's smaller, maybe still the same. So how do you choose your decisions when I can see some residual leak? Should I check for another size at the moment, or let's leave it in place and look at it in 3 months? What's your strategy during the operation in this aspect?
Well, as I've shown you from our data, we had about 10% of patients where we had a residual leak after implantation. Obviously, we tried very hard to avoid that, but in the end, it comes down to there's only a limited number of sizes that you have. So in the end, you leave it based probably largely on the data that we have, that these small leaks do not seem to pose any additional risk, we hope. Yeah, but that is obviously what we do, and sometimes there isn't much more you can do. There isn't a larger one you can implant, because then you have other problems. So sometimes it's the best you can do, and then maybe changing from, let's say, an Amplatzer to a Watchman or vice versa may help you in those cases. But I don't know whether we have people in the room that have actually have that, let's say, experience where they change from one to the other device and then have better closure, because sometimes it may depend on the left atrial appendage morphology, that it can be a challenge with any type of device.
Maybe just on the case basis, we had a patient who had a very oval orifice. I think this varies also. You have more circular, very oval formations. And we had one patient in our series who had a stroke on follow-up where we had a residual leak. So we changed a little bit our concept, and we keep patients on warfarin where we have a significant leakage, and we would like to follow that leakage. So I think leakage is an issue, and if you have a significant leakage, you might have a risk of stroke if you have stroke formation behind and you have flow and communication. I think oval shape is a very important aspect. I think 3D may help us in this case is to identify the size of the leakage.
It's an interesting point, because at least the surgical literatures tend to suggest that it's bad to have a residual leak. But so far in the study that we have, including with the Watchman, there's no sign that at least small residual leak has any clinical significance. But this is something that we need to follow, I think. So I guess at this point it's time to wrap up this session. I think it was a very good start, that first session. And let me just summarize a few key things that they were mentioned this morning. So first of all, John Camm, he just mentioned that the guidelines are changing rapidly with multiple recent updates. And he's suggesting, I think he presented that new oral anticoagulant are now favored over Coumadin in some guidelines, including the recent Canadian guidelines. And certainly, as discussed during the discussion, the role of the aspirin is challenged at this point. The new European guidelines will introduce probably the concept of LAA occlusion, if I understood well. So this is something that we are looking for. Then Torsten Lewalter here present the fact that the new oral anticoagulant are potentially more effective than Coumadin, and potentially more safe if we consider intracorneal bleeding and hemorrhagic stroke. But we need to know that they are associated with a non-insignificant number of major bleeding, still a high number of GI bleeding if we consider, for example, the high dose of the Dabigatran. We know also that the prescription of the newer anticoagulant is limited by the compliance issue. The Dabigatran is a twice-a-day drug, and also is limited by the renal function. Andrew Cook present very nice clip image, and he share different concepts, including where the appendage are coming from. He demonstrated nice things concerning morphology of the left atrial appendage. And he mentioned that there's a wide anatomic variation between between the patient for this structure. David Meerkin present the different clinical trial that he summarized very well. He said that rheumatic AF is potentially a different animals with potentially more potentially more thrombus in the left atrium in comparison with the left atrial appendage. He said that some patients have residual leak, as we just discussed, with unknown significance. And he said concerning referral that the majority of patients seems to come from cardiologists so far for this procedure. And then the last talk was a very good talk also to mention potential subgroup that we should consider for LAA occlusion. With different threshold if we consider CHADS and CHADSVASC score. We also learned that patients with previous stroke are potentially very good candidate for the procedure because they are at very high risk of recurrence. And we also mentioned things about the bleeding risk that we should probably assess in the decision of LAA occlusion.